Hello, my name is Helen Pham, and today I'll be talking about Epoetin Alfa. The objectives for this presentation includes giving a brief overview of what red blood cells are, giving a summary of what Epoetin Alfa is used for, and the clinical implication of using this agent. Red blood cells, or erythrocytes, are produced by our bone marrow. Their purpose is to transport oxygen from our lungs to the organs within our bodies. It also carries carbon dioxide from those organs and be eliminated by the lungs. On the right, you can see a diagram of the red blood cell production cycle. When a stress factor is induced inside an individual's body, the liver and kidney will sense this and produce erythropoietin, or EPO. From there, it will go into the bloodstream and enhance production of red blood cells via the bone marrow. So the two typical stress factors include anemia and hypoxia, and these are sensed by the peritubular cells of the kidney and leads to rapid secretion of erythropoietin, or EPO. So in the scenario of hypoxia, the kidney will produce hypoxia-inducible factors. These are transcription factors that allow for enhanced expression of EPO. Also, the kidney activates polyhydroxylase, which allows for the accumulation of these transcription factors and stimulate the erythroid progenitors in the bone marrow. Here's a diagram of the red blood cell life cycle. You can see at step 1, erythropoiesis, this is the production of red blood cells. When the red blood cells are produced, they take about 7 to 10 days to mature and then circulate in the bloodstream for about 120 days. Afterwards, they'd be phagocytosed in the liver and spleen, where the red blood cell components will be broken down. The heme group will then release the iron, and that is carried with transferrin into the liver and transported back to the bone marrow, where it will be recycled for more production of red blood cells. Now we'll talk about Epoetin Alfa. This agent has 3 different brand names, including Epogen, Prorit, and Retacrit. The drug class for this agent is that it's a recombinant human erythropoietin, or it can also be known as a erythropoiesis stimulating agent. The mechanism of action is that it acts similar to our endogenous erythropoietin. It's typically 165 amino acid glycoprotein that's manufactured with recombinant DNA technology. So with the use of Epoetin Alfa, this decreases the need to use blood transfusion. Although blood transfusion is considered safe, it can carry risk of complications, including transfusion-transmitted diseases such as HIV or AIDS, hemolytic reactions, or even bacterial infections. Epoetin Alfa has 4 different approved indications, including anemia related to CKD, chemotherapy in cancer patients, and Zybutin in HIV-infected patients. It is also indicated in those with reduced allogenic blood transfusion requirements undergoing elective non-cardiac, non-vascular surgery. So what are the effects of Epoetin on erythropoiesis, which is the production of our red blood cells? So there are 3 different effects. The first one is to stimulate the production of colony-forming units, so it allows for more red blood cells to form. 2 is to induce hemoglobin formation and erythroblast maturation, so it allows for our reticulocytes to mature, which takes about 7 days. And then 3 is to release reticulocytes into the circulation, which will allow for the rise in hematocrit and hemoglobin level. So the size of increase in our red blood cell concentration with Epoetin is based on time. And so based on the length of time the medication is maintained, that will dictate the magnitude of increase in our red blood cell concentration. For the administration of Epoetin Alfa, there are 2 modes of administration, including subcutaneous or IV. Sub-Q is the preferred route, except for when the patient is on maintenance hemodialysis or if they're needle-nate, then you would give them the IV route. Epoetin alfa comes in two different forms, the single-dose preservative-free or the multi-dose preserved vials. For the single vial dose or the preservative-free, you want to dilute with normal saline 1:1. However, if you're using the brand IV sub-Q ERYTHROPOIESIS, there's no need to dilute it. For the multi-dose vial, it contains benzyl alcohol as the preservative. We'll talk about why this is important later. The half-life is 4 to 8 hours, and you want to avoid shaking or freezing the agent because it can denature the glycoprotein, making the drug inactive. When dosing Epoetin, you want to avoid patients with hemoglobin of more than 11. For the indication of anemia due to CKD, patients on dialysis, you would initiate them on 50 to 100 units per kilo 3 times a week. Patients not on dialysis, you initiate them 50 to 100 units per kilo once a week. You don't want to increase the dose more frequently than every 4 weeks. However, you can decrease the dose more frequently. So if the hemoglobin doesn't increase by 1 after 4 weeks, then you can increase the dose by 25%. If the hemoglobin does increase more than 1 in any 2-week period, you may reduce the dose by more than or equal to 25%. For Epoetin alfa, there's no renal or hepatic dose adjustment required. When administering Epoetin alfa to a patient, you want to consider monitoring side effects and to note the black box warning on this agent. And so 3 of the big side effects I wanted to mention were absolute iron deficiency, which is a decreased ferritin level with low transferrin saturation, and functional iron deficiency, which is normal ferritin level with low transferrin saturation. And so this is due to the fact that Epoetin alfa actually tells your body to use the iron storage to produce more red blood cells. The third side effect I wanted to mention was that it can increase the risk of seizures. So you want to be cautious in patients who've had history of seizures, or especially those who are taking Epoetin alfa for the first 90 days of treatment. You want to monitor them for seizures. The black box warning for this agent includes increased risk of serious cardiovascular events, vascular access thrombosis, stroke, heart attack, venous thromboembolism, especially in patients who have reached hemoglobin levels of more than 11 or a rapid increase in hemoglobin over 1 over the course of 2 weeks. So that's why you have to be careful when you're increasing the dose of this agent, especially monitoring their hemoglobin and hematocrit. The sudden increase in hematocrit, blood viscosity, and peripheral vascular resistance may require adjustment to their anticoagulation, as well as increase their blood pressure. And so this is due to the agent's effect of increasing risk of thrombotic events, including clot formation, heart attacks, thrombosis in major vessels, or even congestive heart failure. So you want to make sure you adjust the anticoagulant therapy as necessary. And then it can also increase your blood pressure, so you want to make sure you're dosing their antihypertensive therapy appropriately as well. Before you administer Epoetin alfa, you want to consider the contraindications. For instance, the multi-dose vials that I mentioned earlier contains the preservative benzyl alcohol. Benzyl alcohol is associated with high risk of fatal toxicity in neonates, infants, pregnant women, and breastfeeding women. The toxicity is known as gasping syndrome, so you want to avoid administering it to these patients. You also want to avoid uncontrolled hypertensive patients, or even those with allergies to mammalian cell-derived products or albumin, because these ingredients may be involved in the agents. The patients with cancer receiving hormonal agents, biological products, or radiotherapy, undergoing cardiac or vascular surgery, or receiving cancer therapy, you want to avoid those patients as well. And then due to the delay of erythropoiesis, or the production of red blood cell, it's contraindicated to use Epoetin Alfa to acutely correct severe anemia or emergency transfusion. So here are some of the drugs that may interact with Epoetin Alfa, including anti-neoplastic agents and androgens. So you want to avoid using these agents with Epoetin Alfa because they can enhance the effect of producing more red blood cells, so you might be producing way more than you anticipated. When monitoring a patient on Epoetin Alfa, there are two main labs you want to look at, including hemoglobin and hematocrit. Hemoglobin is the measure of amount of hemoglobin in your blood, and then hematocrit is the measure of how much of your blood is made up of red blood cell. Here I've listed the normal ranges for each level. So if a patient comes in with low hemoglobin or hematocrit, it may be due to their anemia from vitamin deficiency, bleeding, or chronic disease. If their hemoglobin or hematocrit is high, it may be due to them being dehydrated, or they have blood cancer where their bone marrow creates too much red blood cells. When you monitor hemoglobin and hematocrit, you want to do it weekly after initiation and then prior to readjustment of the dose. If the patient is stable, then you can monitor it monthly. You may consider ordering hemoglobin and hematocrit levels if there is a trend in the patient's lab. So if the hemoglobin is more than 10.5 and it's been increasing, you may want to order the levels just to make sure they don't go over 11. If the patient's serum ferritin is less than 100 and the transferrin saturation is less than 20%, you want to administer supplemental iron before treatment. If the patient has inadequate or no response over 3 months of readjustment periods or escalation periods, you may stop the treatment. For prevention of further complication, if the patient's hemoglobin goes over 100, you want to hold the dose or stop the treatment because it can increase the risk of serious cardiovascular events, including heart attack, stroke, or VTE. You also want to reduce the risk of thromboembolism with these lifestyle changes, including smoking, alcohol cessation, regular exercise, and diet modification. To end the presentation, I just wanted to mention clinical implications when administering Epoetin Alfa. And so when giving this medication, we want to work as an interprofessional team in managing this agent. For instance, pharmacists can verify the dose and ensure no potential drug-drug interactions occur. Nurses can ensure that they administer the agent appropriately, whether it's IV or sub-Q. And then, based on the patient's response and their levels, the team can determine the appropriate duration for the treatment to prevent any complications. And here are my references. Thank you.